Good morning, everyone. I'm Dean Ambrosini, Project Coordinator for the West Hollywood Project at the Institute for Public Strategies. The West Hollywood Project is funded by the County of Los Angeles, Department of Public Health, Substance Abuse Prevention and Control, and works to reduce substance use-related harms in the city of West Hollywood through community building, media advocacy, and systems change. I'm joined today by Roger Sediles. Roger is the Program Manager of Substance Abuse Prevention Programs at APLA Health in Los Angeles. He began working at the HIV prevention field in 2007 as a prevention training specialist for the PartyWise program, a harm reduction-based HIV prevention program for gay men who use meth. After identifying the needs of Latino multilingual speaking gay men who are active crystal meth users, he also developed and incorporated a curriculum in Spanish for this particular population, which assists in providing more culturally appropriate HIV prevention services for this group. There we go. Oops. All right. During this presentation, we'll discuss meth use in the LGBTQ community, specifically among gay men. We'll look at meth use in that community, risk factors driving use, and the impact of meth use on HIV infections. We'll also examine harm reduction as a method of prevention to help mitigate the impact of crystal meth use. Harm reduction is a polarizing topic, as we'll learn in this presentation, which is surrounded by a miasma of stigma. We'll look at that stigma, the perceptions behind it, and work to dismantle those theories. We'll also learn promising harm reduction strategies currently in use and their impact on HIV and other disease transmission in the community. According to a recent study by the National Institute on Drug Abuse, meth overdoses are on the rise. According to data analyzed between 2015 and 2019, meth overdoses in the US almost tripled. During that time span, meth-related overdoses rose from 5,526 to 15,489. This was accompanied by a 43% increase in people who reported using meth. Researchers believe that over 2 million adults used meth during the period, up from 1.4 million in years previous. Crystal meth is a highly addictive and somewhat uniquely addictive drug, which acts on the dopamine sensors in the brain. People who use crystal meth often progress to being fully addicted very quickly. The LGBTQ community has historically seen higher rates of substance use in general, and meth use is estimated to be 4 to 5 times higher than in the heterosexual community, particularly among men who have sex with men. Meth use during sex leads to risky behavior, which increases the impact of meth use to include higher HIV infections and other sexually transmitted diseases, as well as increased hepatitis A, B, and C infections. In looking at crystal meth use among gay men, West Hollywood provides a unique statistical basis on the epidemic. Although recent demographic shifts have brought changes in population density, West Hollywood has long been and remains a major LGBTQ population center from its nightlife to its city government. As a result, we are seeing that the current rise in crystal meth use has had a heavy impact on the city. As you can see from the slide, meth-related visits in the area around West Hollywood tripled since 2005, and it ranks the highest in treatment admissions and hospitalizations. Most men who use crystal meth stated that they were introduced to the drug by a sexual partner or in a sexual situation. And this creates a perfect storm for meth-related harm and compounds the difficulty in battling crystal meth addiction. Meth acts on the brain, on the same pleasure sensors in the brain that become activated during sex, which creates a link between the drug and sex that can be difficult to break. Meth is also a neurotoxin, which destroys dopamine sensors, leaving users unable to experience pleasure without the drug. The drug boosts the release of dopamine, leading to an increase of this chemical in the brain. Dopamine is associated with motor function, reward, and the brain's pleasure sensors. Crystal meth causes an intense, elevated, or euphoric mood that is stronger than cocaine. Experiencing these unnatural levels of dopamine causes a strong desire to continue using the drug. It becomes addictive because your body experiences intense cravings to maintain the extremely euphoric state, which often results in continued constant redosing and binge-like behavior to achieve that goal. And this creates a unique dynamic of addiction for gay men. The combination of stimulant drug use and sex creates a super high that is more potent than the drug alone. Individuals who experience these potent effects become addicted not only to the drug, but to the combination of the drug and sex. For these individuals, the sex and drug link becomes inseparable, and this creates a constant level of craving and relapse that is really a large contributor to the program, or to the problem of meth addiction. It's difficult to find accurate, consistent statistics to represent recovery from crystal meth addiction because there are so many benchmarks used to measure success in 12-step recovery programs and inpatient treatment programs. Success is measured usually by sustained total abstinence from all substances, including crystal meth. There are few statistics on people who are able to stop using crystal meth while continuing to use other substances in a non-problematic way. Estimated figures for gay men who experience crystal meth addiction show that less than 6% are able to sustain full and ongoing abstinence, and most have 7 failed attempts before getting there. And considering the complexity of crystal meth use among gay men, the impact it has had on health and the impact it's had on health outcomes overall, it's important to address the problem at every level. Standard prevention methods only go so far, but they help to educate the community about the dangers of meth use in an effort to stop first-time use. Prevention can also be a useful tool to help recognize the signs of addiction, to help guide problematic users of the drug to seek help. But this leaves a gray area between preventing the problem and treating the problem once it reaches the stage of addiction, and harm reduction methods have shown to be an effective tool in mitigating the damage of the drug on the person and the community. Harm reduction programs have been in place for many years. During the AIDS crisis in the 1980s and 90s, syringe exchange programs were started to prevent sharing of injection drug materials to help slow the rapid rise of disease transmission among injection drug users. Although these were proven to be successful, this method of harm reduction became immediately controversial, and it created a stigma around harm reduction that continues to this day. But harm reduction has actually evolved beyond syringe exchange programs, and it is now a multi-level strategy with a proven track record for reducing drug-related damage. But the stigma continues to proliferate, which makes public support for harm reduction programs difficult to attain. In order to break down this stigma, it's important to understand what stigma is, but I think it's also important to realize that the word harm reduction is automatically associated with what was at the time called needle exchange and is now called syringe service programming. And many people still attach that stigma to all forms of harm reduction. But stigma in general is a social process which reinforces relations of power and control. And in relation to harm reduction, stigma plays out in a lack of public support, as I said. Stigma is shaped by our thinking. It's a bias or a perception that substance users are bad and immoral rather than suffering from a chronic condition that requires care and treatment. Stigma is communicated by words, language, tone, interpersonal attitude, indifference, and body language. It's also a preformed judgment where you just generally glance at someone and label them as a drug user, and that can be extremely dangerous for the person who's seeking help. Stigma becomes internalized when the person seeking help is literally barred from getting help because they internalize what they believe that society believes about them, as complicated of a sentence as that is. But, they view themselves as bad or weak, which fuels the shame, and that continues to drive them further and further into their addiction. When it comes to harm reduction, this stigma has created assumptions that it enables drug use, that it also ignores the negative outcomes of drug use and rewards the negative behavior, because effectively you're supplying people with the tools in certain cases where syringe exchange and other programs are concerned. You're supplying them with the tools to continue in their addiction. And it's very hard for the public in general to reconcile that as a life-saving measure. You know, and these assumptions are unfounded. Harm reduction actually acknowledges the use of drugs and seeks to mitigate the consequences without judgment. Harm reduction is not an anything goes approach to drug use. Harm reduction acts as a bridge between active use and abstinence to help reduce problematic use of meth and the outcomes of problematic use. Harm reduction does not enable drug use and encourages safer methods of use to protect the health of the person using drugs. And it doesn't exclude or dismiss abstinence-based treatment programs, but it basically keeps people alive. You know, abstinence is a terrific goal for drug treatment and really probably the only success to be had. But if someone overdoses or acquires a fatal illness, they can't get treatment. So what harm reduction does is continues to keep them alive and engaged until they can seek sustained recovery. Harm reduction meets people where they are, but it doesn't leave them there. It's, it's a spectrum of strategies and methods which encourage less harmful practices while using drugs. It recognizes the individual and allows people who use drugs to act as their own agents of change. Some of the harm reduction methods currently in use are syringe exchange services, as I mentioned earlier, formerly known as needle exchange, which are the most common tool in use today. There's also medically assisted treatment for opioid use disorder. It's important to note there is promising success shown with certain treatments in research for meth addiction, but there isn't any workable program in place yet. Harm reduction programs also provide safer smoking supplies, which, although that seems to be another level of enabling, it actually helps injection drug users find a less harmful method of use. And we've all heard about supervised injection sites, which they're not currently available in the US, but they have shown promise as a solution in European countries and are worthy of investigating. Harm reduction also provides overdose prevention education, Narcan distribution, which can help to prolong the life of the active user for obvious reasons. And it also offers education, therapy, and discussion groups aimed at managing, reducing, or resulting in safer drug use. Despite the controversy, harm reduction programs have shown great success in combating drug-related harms in the communities with active programs. Harm reduction programs have been shown to reduce HIV infection as well as other sexually transmitted illnesses and hepatitis by up to 50%. And they do provide a linkage to STD treatment, substance use disorder treatment, and other services because they act as a point of engagement for people actively using drugs. And they reduce discarded syringes. Most syringe exchange programs take in more than they give, which is an interesting note. Harm reduction programs, particularly syringe exchange, are a tool that can help reduce transmission of viral hepatitis, HIV, and other bloodborne infections up to 50%, as I said previously. Transmission of these diseases, in addition to reducing the infection itself, is reduced by more than 2/3 by not sharing the injection equipment. According to the Centers for Disease Control, there's been a decrease in HIV diagnoses attributable to injection drug use. And then that trend began in the mid-90s when syringe exchange programs first began. Reduction in HIV infection as well as hepatitis C has had an impact on healthcare spending, as the average estimated lifetime costs of treating one person with HIV is near $450,000. Hospitalizations in the U.S. due to substance use-related infections alone cost over $700 million annually. Syringe exchange programs facilitate entry into substance use disorder treatment for people who inject drugs. As I said, they often act as a point of engagement. People who are using drugs, the injection drug users, usually show a high readiness to reduce or stop their drug use. They're certainly looking to mitigate the damage. There's also evidence that people who inject drugs who work with a nurse or a practitioner at a syringe service program or other community-based in venue are more likely to access primary care than those who don't. Syringe service programs can also reduce overdose deaths by teaching people who inject drugs how to prevent and respond to a drug overdose, providing them training on using naloxone, and how to, many SSPs also provide overdose prevention kits containing naloxone to people who inject drugs. SSPs, which is syringe service programs, I'm going to shorten that for going forward, have partnered with law enforcement in providing naloxone to local police departments to help keep them and their communities safer. There's also been a huge impact on public safety. A study compared the prevalence of improperly disposed of syringes and self-reported disposal practices in cities with SSPs, San Francisco, for example, to a city without an SSP, which is Miami, Florida, and found that 8 times as many improperly disposed of syringes existed in Miami than did in San Francisco. And this was taken as surveys of public waste picked it up off the street. People who inject drugs in San Francisco also reported higher rates of safe disposal practices than those in Miami. The CDC, through their national HIV behavioral surveillance system in 2015, showed that more syringes were distributed at SSPs for people who inject drugs in a geographic region, and the more likely people who inject drugs in that region were to report safe disposal of used syringes. Evidence demonstrates that SSPs do not increase illegal drug use or crime, and this is often the perception when a syringe exchange site opens in a neighborhood because people think it's going to attract crime. But studies in Baltimore and New York City have found that no difference in crime rates exists in those areas where SSPs are located. In Baltimore, trends and arrests were examined before and after an SSP was opened and found there was no significant increase in crime. In New York City, there was an assessment done as to whether proximity to an SSP location was associated with experiencing violence, and they found no association. This brings us to the question as prevention providers as to where harm reduction fits into the spectrum of our work in prevention. We tend to work in an upstream approach to addressing substance use. I know my program does, but harm reduction weighs a little farther downstream, but harm reduction is a multifaceted program, as I stated, and we are working to mitigate the overall harms on the communities, and harm reduction is a useful tool. And we can employ that as prevention providers by mobilizing our coalitions to help interface with governments to help enact policy changes aimed at furthering funding and support for harm reduction programs. We can also continue to build stronger communities to rise to the change, or rise to the challenge of crystal meth use, and that work is certainly effective as well. And excuse me. And at the individual level, by targeting the population who uses crystal meth in a more direct way through our messaging to help educate and inform about the risks of meth use and how to mitigate them. In short, basically letting them know that there is a bridge between recovery or sustained abstinence and active use, and that lies in harm reduction programs, and then educate them on how to find them. Great. I'm going to go ahead and turn it over to my co-presenter, Roger, who will speak about programs currently in place at APLA Health in LA. Roger?
Thank you, Dean. Thank you so much for the information that you share. So let me share that screen real quick. Hello, everyone. Once again, my name is Roger Sediles. I am the program manager of the substance use programs here at APLA Health in Los Angeles, California. And today I'm going to talk about the harm reduction-based HIV prevention programs that we have in place currently. So just to mention, just to make sure that you know, under the substance use programs, we have Pennywise, which is a crystal meth program for gay men who use methamphetamine, funded by the Los Angeles Department of Public Health Division of HIV and STD programs. The program aims to empower participants to make informed choices to reduce the negative consequences related to the use of meth and their sexual behaviors. Project Impact is a youth program for queer men of color 18 to 24, funded by the Substance Abuse and Mental Health Services Administration, designed for individuals seeking support in the areas of substance use, abuse, sexual health, and HIV prevention, also providing linkage to HIV, STD testing, and treatment PrEP. But today we're going to focus more on the Pennywise program, which is the program that has been running since 2005 here at APLA Health. So this program was developed in consultation with Rafael Diaz and the Cesar Chavez Institute, funded by the County of Los Angeles. And it's a harm reduction-based HIV STD prevention program working with active crystal meth using MSMs, or men have sex with men, since 2005. Once again, the program goals are to reduce the opportunities for active crystal meth using MSM to acquire or transmit HIV and STD, Hep C, through their sexual and drug using behaviors. So we know, as Dean already mentioned, there are a lot of public health issues related to meth use. And just to add to everything that he shared with us earlier, according to a data brief from March of 2000 by the Los Angeles County Substance Abuse Prevention and Control SABC at the national level, 185,000 individuals initiated meth use in 2017. According to the death certificate data from the Center of Disease Control and Prevention, the number of deaths in LA County listed meth poisoning as a cause of death and drug overdose as the underlying cause of death increased to 707% from 43 people in 2008 to 347 in 2017. According to Los Angeles County, Latinos accounted for the majority of clients with a primary meth problem, with a 63%, followed by white 22%, black 10%, and Asian Pacific Islander 2% from years 2017-2018. In 2017, 66% of clients who reported meth as the primary drug problem had used meth before or during sex in the past year. So why harm reduction? Other than what we already mentioned, injection and non-injection drug use in men that have sex with men are at a very risk for HIV infection. It may, in many occasions, active drug users also happen to fall out of the system for HIV and STD distant treatment, maybe because they are not ready to access drug treatment services. When experiencing withdrawal, a person can experience irritability, body aches, anxiety, leading to a lower number of services available to them due to client or patient and services provider interaction. A lot of times the client doesn't trust the doctor, doesn't trust the clinic that they go to, or just the provider doesn't know how to work or is not prepared to work with someone that is going through withdrawals. Despite the belief of many service providers that substance users can't maintain or even start their HIV treatment due to their drug use, in our experience, 95% of our program participants have been capable of maintaining medication adherence. Methamphetamine use impaired judgment, decision-making. Party and play leads to an increased number of sexual partners, and party and play, by the way, refers to having sex while using methamphetamine. And not knowing the risks related to needle sharing and the options to reduce the risk. also increase the risk for HIV and STDs, high number of untreated STD infections within individuals not interested or ready to access drug treatment services, increase the risk for HIV acquisition and STD transmission. When not aware of risk, HIV-positive methamphetamine using men who have sex with men could decrease medication adherence, which in some cases threatens viral suppression, increases the opportunity of transmission. What I mean with that is a lot of times people who use methamphetamine think that they should stop their HIV medication when they use methamphetamine because they don't know of the interaction between one and the other. And as a harm reductioner, we try to empower them to continue the medication and not to stop using the medication, even if they are using methamphetamine, because as we know, the virus can mutate, get stronger to the medication that they are using. And so we try to keep them taking their medication and adhering. So some of the activities within the PartyWise program, so we do outreach virtually and in person, link referrals, whether it is to HIV, STD testing, PEP, PrEP, and even services that are not part of our scope of work, but are needed by our target population, like housing, food banks, mental health services, drug treatment services if the person is ready to access them, needle exchange, and others. Individual health navigation sessions and 30-day follow-ups. So we facilitate 2 health navigation sessions with clients where we can talk about the risk, we can talk about the harm, the ways they use, giving them information on how to reduce this harm and risk, and also give us an opportunity to link them into HIV testing, STD testing, HIV treatment if they are positive and out of care. We also set up goals on these sessions. Any goals that they decide to, it could be decreasing the number of sexual partners, could be accessing PrEP or just getting an HIV or an STD testing. And then on our 30-day follow-up, we are able to check in with them and see if they were able to reach their goal, and if not, find ways that we can support them to reach their goals. Also, we have contingency management integration into PartyWise under the HSP funding. With the existing scope of work, contingency management is a strategy used by in alcohol and other drug treatment, and it encourages positive behavior change. And this is a new part of the program. All activities occur over a 12-month period. Also, other activities, we have a reintegration under Sierra Health Foundation funding for Black and Latino MSN who use meth. Also, virtual and in-person outreach, monthly English and Spanish harm reduction based groups, 3 sessions exactly. And we cover topics about crystal meth, basic crystal meth 101, ways to reduce the harm, strategies, the harm related to meth, how to reduce the risk, needle exchange, mental health services, HIV, STDs, Hep C, triggers in addiction, how to identify your triggers, what works for you, what doesn't work for you, what's realistic for you, etc. And we also do a 30-day follow-up after these sessions, and we give us again the opportunity to check in with them, see if the information that they learned was useful, if there's anything that we need to clarify, if there is any services that we can link them into, or re-link them into. And also we have the distribution of fentanyl test strips and naloxone spray to program participants as requested. Currently, a total of 1,407 test strips have been distributed between July 2021 and October 21 here at APLA Health. So let's talk about some of the challenges and successes within the PartyWise program throughout the years. So the substance users are not ready to seek and receive drug treatment happen to fall out of the system, as we said earlier, for HIV and STD testing and treatment, making it harder to re-engage them into these type of services. Clients express their fear of blood and urine tests for HIV and STD because of their belief that they might be tested for drugs without their knowledge and be reported as well. Program participants express lack of confidence in themselves, in most cases, accept defeat before trying to make any changes. Misinformation about HIV treatment and medication interaction with substance use, like I mentioned earlier, fear of an HIV test result while dealing with their drug addiction. Some of the responses that we have, assists clients in the creation of social support network for HIV and STD testing and referrals to other services, include former and current participants in the implementation of program planning for outreach, provide accurate and reliable information about testing and treatment, refer to reliable services providers, people that you know that will be able to work with the clients, explain what can be reportable and what is not. To clients, that we're not going to report them to the government, that we're not going to test them for drugs without their knowledge or anything like that. Give clients ownership of their own process on creating a pathway to recovery. Use free HIV and STD testing to get clients to our doors. So even when maybe they are not ready to be part of our health navigation sessions or our groups, our workshops, we offer clients the opportunity to come and test with us so that they feel more comfortable and give us an opportunity to talk to them about the other options, the other services that we have, and make sure that they know that our services are non-judgmental and it's a free space and that we understand their issues. Ask all participants about their HIV and STD status through an intake form. All participants are referred to HIV and STD testing from the first moment we meet with them, and they decide if they want to do it then or later throughout the sessions or the groups. HIV negative clients are offered PrEP services when appropriate. Medical care adherence is discussed with HIV positive clients during health navigation sessions. These services are offered inside or in our clinic next door. Reduce client stigma on HIV and STD testing treatment by making it routine. Partnering with mobile testing units or needle exchange units during outreach. Remind group participants about the availability of HIV and STD testing as much as possible during intake groups and health navigation sessions, even throughout the follow-ups as well. And we have also just have to mention that we have at-home testing where we can, HIV testing, where we can send their test box to their home. We have testing here at our clinic, so we have different options for the client. Some of the demographics for data collected from 2019, 2020. So the majority of clients identified as gay cis men, 200 clients, with the exception of one cis bisexual man. 90% or 40 were homeless, 131 clients rent or share a unit, 27 other living arrangements, and 3 own home. Race and ethnicity, 107 Latinx participants, 65 Black African American, 20 white, 4 Asian, 2 Native American Alaskan Native, and 1 Pacific Islander, and 1 that was other and non-Native Hawaiian. Some of the successes we have in through this contract year 2019-2020. So the use of substance, whether in exchange for sex or for recreational use, was very common among program participants at the point of intake. A total of 86.5% of clients reported having had exchanged drug for sex in the past 6 months, while meth was the predominant substance used, with 100% of clients reporting having had used it. Other substances were reported as well. A total of 79 individuals were referred to PrEP services. 27 program participants were linking to HIV testing. 73 program participants were linking to HIV and STD testing simultaneously, and 97 program participants were linking to STD testing. A lot of times, clients who decide to test only for STDs, most of the times it's because they already have a HIV positive diagnosis. with a total of 197 participants linking to HIV prevention services. 201 clients committed to change the sexual drug using behavior, and 150 of them reported to reach their goal and show change in behavior. Other data that we collected from 2014-2018, we identify and recruited high-risk individuals and their peers who may not have access HIV and STD testing through conventional HIV testing programs. So from July 2014 to June 2018 only, we had a total of 801 participants who completed our 4 sessions with workshops. Within these years, a minimum of 475 clients were tested for HIV and STDs each contractual year, with a total of 1,903 individuals tested for HIV and STDs. 184 former group participants completed 3 or more weekly support groups after completing the workshops, and 38 former group participants completed a 16-hours peer health educators training with a minimum of 85. So the peer health educators training was a part of the program that we had before, and we will choose or we will look into individuals that were participating who will normally refer other participants to the groups, and we will ask them if they wanted to become peer educators, give them a training on the different subjects that we talk, so that they can have conversations with their friends and you know, at home or wherever they socialize. And these peer educators had to do a pre and post test, and the post test have to pass with an 85% score, at least minimum. Some of the lessons learned: it is vital to reinforce clients' confidence, remind them that they are competent to make choices and changes in their lives. Service providers, important to remind ourselves that not to take clients' actions personal. Keep in mind that change cannot be imposed. So it is really important to make sure that they are making the decision of what changes they want to make and support them in that. And rewards and encouragement are more effective than punishment and judgment. It is essential to make sure that your testing department or allies understand your clients, their behaviors, their fears and challenges. Same as with harm reduction strategies for drug use, when illustrating the benefits of knowing clients' HIV status, testing for STDs, adherence, PrEP, and other strategies to minimize risk. Clients seem to be more receptive when the information is presented by their peers who have already accessed the services with us. Clients' misinformation is hard to amend even when you are providing accurate information, and it's difficult to change their beliefs about HIV and STD testing and treatment. So you and your HIV STD testing partner should be aware when giving information to clients that the client might not always trust in the information that you're giving them. So some of the things that are coming soon within the PartyWise program, we have the implementation of Getting Off curriculum. It's an 8-week, 24 sessions gay-specific behavioral therapy intervention that follows the manual of Getting Off, a behavioral intervention for gay and bisexual methamphetamine users. We also have weekly harm reduction-based groups coming up, other than the groups that we already have. Monthly digital campaign on Grindr and other social media venues, and quarterly town halls community forums about meth to increase community awareness. And that's my presentation, everyone. So thank you so much.
Thank you, Roger.
Thank you, Roger. Sorry.
Oh, sorry.
Yes, so sorry. I was trying to unmute and it was not working for me. So thank you, Dean and Roger. Great presentation, great information. And now we will move into our question and answer section. And so before we do that, we do have a survey for our attendees to complete. This is just a quick evaluation, so you can scan the QR code, and we will also share the link in the chat. So whatever is easier for you. The link will also be sent out via email, but I know sometimes those emails get lost. So if you can do it just quickly, we would appreciate it. It helps us plan for future webinars and provide some feedback for our wonderful presenters. And I also do want to note that IPS does offer training and technical assistance. So if you are interested in any of that, you can email us at info@publicstrategies.org, or you can also visit our website for kind of more information of what we specialize in. So I'm going to hand it on over to Nancy, who's going to help us with our Q&A.
Muted. I added the website on the chat if you're interested in that. And so the first question that comes in is by Maria Rosie. And the question is, has there been any type of campaign to teach the fact that it kills the pleasure centers experienced by sex? It seems like it's a very evil story that has been propagated. Imagine it kills the pleasure and you develop a substance use disorder. If not, we need to work on it. So I don't know if
answer that. There's no specific campaign that teaches that, but I can say that the Meth Free LA program through the County of Los Angeles is working to get more information out about the various and sometimes unknown effects of meth. And it's a very well-crafted education program to help reach out to the public and let them know if you're using meth, what you're getting into. I don't know what's upcoming in that directly offhand, but I have seen the campaign, and as I said, it's very effective. Regarding the pleasure sensors and the link between meth and sex, it actually can be broken. Thankfully, the brain restores itself after a period of time, and those sensors tend to reset to normal. However, it's varied as to how long it can take, and it's estimated to take, at the best estimate, 14 months to up to 2 years.
And I would like to add to that, Dean. I have seen a very small information on campaigns, but I do have to say that throughout our health navigation sessions and workshops, those are some of the subjects and the topics that we talk about with clients, and we let them know that that's part of the harm that can be, caused by the use of meth.
Thank you. And the next question is, what is the most popular way meth is used? Is it injected, smoked, snorted, or eat it?
Currently, I believe the most common is smoking, followed closely by injection, which is on the rise when it comes to gay men in particular. I do know that in the general population of people who use meth, smoking is the most common form of doing it. The others, snorting and eating it, are also used, but I believe actually smoking is, from what I've read in research, it is the most effective delivery system as far as getting more for your money, if that makes sense. And it is the most widely used as well.
Right. Can I add to that, Dean? We do talk about this in our groups, and we have identified that that's one of the most addictive ways of using methamphetamine as well. Smoking is the cheapest, it's the easiest, the coming down is less severe, and so we let people know this is going to be the most addictive way. And then we talk about the most dangerous way, which is injecting the drug. Then we talk about how swallowing could be less harmful, although it doesn't take away the harm, but it will be less harmful than injecting it, because injecting it crosses all your protection barriers in your body. But yeah, we also cover those type of subjects as well during our presentations.
Thank you both. The next question is, what upstream prevention strategies, if any, are underway to reduce meth availability within the community? What collaborations are in place with local bars to advance responsible hospitality practices?
Well, I can speak to the West Hollywood project, and as I said, West Hollywood is a really good microcosm of the gay society because it does have a largely LGBTQ government and a very mobilized voting public. And we do have a coalition called the Safe West Hollywood Community Coalition. And we're working directly with the city council to help enact a series of recommendations that we've made through a data-informed study that we did to help reduce the damages caused by crystal meth within the community. As far as reducing the availability, that's a bit more in the law enforcement and public safety camp. And we do participate in efforts with that as well, as far as certain other programs and coalitions that are working with the Board of Supervisors to help curb the availability on the street. And then, of course, as far as meth use in local bars, I mean, we've shown that it's through a survey that we conducted at 2 of our events, we've shown that, you know, there is knowledge of the use at the bars, but we do provide responsible beverage service and service training within the community that we serve, and many other programs do that as well to help get the hospitality community on board. I hope that answers your question.
Thank you. The next question is there a website or email we can reference when we are approached by friends struggling with meth use? How can we easily direct people to all the programs being discussed today?
Okay.
I will.
Roger, do you want to? Yes.
If it's possible, we can send an email back to the participants with the contact information of Dean and myself. So definitely, so they can access services with us here at APLA Health if needed.
Yeah, thank you for that. And I'll also go ahead and drop that information in the chat in a moment. So the next question is, can you tell us a bit more about safe smoking programs?
It's new news to me, and I will give credit where credit is due. I was made aware of this through Being Alive, which is a syringe service program in the West Hollywood area. And it is a method of stepping people down from injection drug use. My initial reaction to the idea of giving meth users a pipe was, and forgive my language, hell no, what a mistake. But when it was explained to me by the facilitator of that program that it's less dangerous than syringe use, and that they promote it as a method of stepping down from injection drug use to a less damaging method of use in administering the drug, it made perfect sense. And there were also statistics that were given to me at that time that also showed that having, you know, clean materials available has an impact down the road. I mean, there's certain mouth-to-mouth transmitted diseases right down to COVID. The spread is affected by having those clean materials available. It's given with a cleaning kit. It's not done, you know, they're not out on the street throwing them out to everybody who's using them. It is quite new news to me, as I said. I came across it in a webinar similar to this, and certainly intrigued, and it does show promise.
Thank you, Dean. And for Roger, any advice on how we can get a party-wise program started?
I'm sorry, can you repeat the question? I'm sorry.
Of course. Any advice on how we can get a party-wise program started?
I couldn't hear the last word that you say. Survey, you said?
A party-wise program started?
Oh, it started. I think the most important part is making sure that the staff is non-judgmental, that they are prepared to work with individuals who are at any a point of their use. They could be trying to quit already. They could just be not even considering to stop using, and really trying to identify what is it that they want to do next, and support them into that. Give them as much information as possible, and not assuming that everybody that comes to your door, just because they are using methamphetamine, they really have the knowledge about what the drug is, what it does to their bodies, or anything related to it. In fact, with Latinos, I have to say the issues are different. Like in our experience, we've seen that a lot of our Latinx community, they show here not having any information, already feeling addicted to the drug and not knowing, not even what they are putting in their bodies. And it was because someone was give it to them. Some people do it for work, like because they have to work extra hours, and someone say, hey, take this medication, it's gonna help you stay up. And at some point they don't know what to do with it, and they just know that something's wrong. And really, just like trying to work with the clients and having a large referral network for services, as many services as you can. That will be the most important part. It is, I gotta say, it is challenging sometimes to get people into treatment, for example, for drug treatment or other services like that, because the window period for someone that is ready to make that change is very short. And so you have to be ready to jump in it and really try to help them get there. And I will say that we're open to talk to anybody who wants to put a program like ours in their cities or in the organizations, and help them with our experience a little farther more. Okay, I hope that answers the question.
Thank you. And Eric says, thank you for the presentation. And another question for you, Roger. As a mental health provider at Kaiser in Los Angeles, what is the best way for my patients to access your program? And do you have any flyers, literature to share?
So we, at the moment, we don't have any flyers, but we do have our website at APLA Health, and people can contact us anytime to the information that you're going to send them. My number, if you need it right now, 323-329-9908. But so really, people can just contact us, give us a call, tell us what, that they hear about our program and they want to start working on or find out more about crystal meth, whatever is the case. If your client would like to participate in these harm reduction based programs, we will help them and talk to them, see what works best for them. What services that we offer works best for them.
Thank you. The next question is the meth overdose rate increasing due to intentional, unintentional use of fentanyl? I know that fentanyl is increasing overdose in use of other substances.
I'll take that one, or I can take that one, and we can both take that one. Yes and no. Fentanyl is showing up in all street drugs, as many people have heard in news reports, and it is showing up in the meth supply as well. It makes no sense to mix a sedative with, with a stimulant for marketing purposes, but we're not dealing with marketing geniuses when it comes to drug sales. But I do know that from the statistics that I used and have read, that the final decision as to what the cause of death was is made by the tox screen that comes back from the coroner. So while it is having an impact on overdose rates among meth users, the final cause of the overdose death, if fentanyl is involved, would be listed as fentanyl and meth, or one or the other, depending on what was determined to be the actual cause of death. So I can tell you that it is having an impact, but as far as increasing the statistics, it's attributed to what knocked them over the edge, if that doesn't sound too insensitive. Yes.
Thank you for that, Dean. And this one's directed at you, Dean, as well. You mentioned community playing a role in possibly preventing or reducing harm? Could you talk about how you see communities partnering with providers to end, prevent, or curb meth use?
Absolutely. Our coalition, the Safe West Hollywood Community Coalition, as I said previously, is working to bring forward a list of recommendations to the City Council and how to implement those to help reduce the harms in West Hollywood. Those coalitions are, of course, open to the public, and we welcome support from general members of the community. There are several others throughout the city and county that are also mobilized to do the same, and they are partnering directly with prevention providers, as well as working as the voice of governments. And it's kind of difficult to some extent, because those of us who work in prevention for LA County, you know, we are part of the government arm, but what we can, you know, so we can't directly, you know, our purpose is to bring the public forward and to help amplify their voice through our coalitions that we sponsor. And that's what's having the impact right there. So I do know that Wall de las Memorias, through the Act Now Against Meth campaign, is working to bring forward a list of recommendations based on a town hall that they did with regular citizens to help address the meth epidemic, and at several other levels throughout LA County.
Thank you.
Nancy, I'm sorry to interrupt. I just wanted to go back to that last question prior to this one about fentanyl overdose. I just wanted to say that for us, we have seen an increase of overdose. It's hard to say, you know, if it's fentanyl, but it happens and it has happened. We have seen cases that have been reported to being, you know, to their drug being mixed with fentanyl, and that's the cause of overdose. We know that fentanyl makes drugs extra stronger than what they are. And if people are not looking to get high on fentanyl, they just don't know the consequences of it. And so that's what causes the overdose, because it's more like unintentional use. That's what we've seen, and that's why we made an effort to make sure people have access to the fentanyl test strips so that they can test their drugs and prior they use them, and make a more conscious decision or informed decision, if you like, you know, maybe the amount that they're going to use, maybe not use it at all, you know, or you know, maybe just use it less. I don't know. You know, so we do make sure that that happens, because we have seen an increase on overdoses due to fentanyl.
Got it. Thank you for that, Roger. And I know that it is 11 in a minute here, and if you want to stay for, it's just 2 more questions for Q&A. But the next question is, what conversations do you have with your clients about adverse childhood experiences and toxic stress?
I think that's more for Roger.
Yeah, I imagine. So we really have not touched the subjects. Not a lot of our clients really have kids, you know, so I don't know. I wouldn't, yeah, I can really not answer that question. I apologize.
Okay.
Thank you, Roger.
Thank you, Roger.
You're welcome.
And as far as harm reduction impeding prevention efforts, that would be my initial assumption, honestly. But it doesn't, it broadens it, and it awakens us to the fact that prevention, especially where crystal meth is concerned, takes place a little farther downstream than we usually go. This is a problem that's already in play, and it's an addiction that requires a great deal of struggle, or actually involves a great deal of struggle for people getting into the recovery system. So I think the prevention efforts need to shift focus from preventing initial use to keeping people alive until they can actually get off the drug. And I don't think it impedes it as much as it broadens it. It just definitely is a call to action that our prevention efforts don't just stop with, you know, just say no, because some people have already said yes. And the fact that they've said yes is creating damage within our communities. And for that reason, we need to continue to have those prevention and mitigation efforts to help reduce the harms around the drug use.
And the question that Dean is answering is, does encouraging harm reduction practices impede use prevention efforts? So thank you for your response, Dean. Did you want to add?
Sorry, Nancy, I talked right over before you.
No, you're good. You're good. All right. So I think that's it. Those are all the questions we had.
Yes, thank you, Nancy. Thank you for handling the Q&A. Thank you for all of our attendees who stayed with us at 2 past the hour. We do appreciate it. And thank you so much, Roger and Dean, for the wealth of information that you guys shared today. It's much appreciated. As I said before, we will send out the email with information for both Roger and Dean. I will be sure to include their contact info in there, as well as a copy of the slide deck. And yes, a recording of the webinar will be available on our YouTube channel before the end of the week. So thank you all for being here. Thank you again, Roger, Dean.
Thank you, everyone,
for all your help.
Thank
Have a
you.
wonderful
I'm glad
day.
you've been here today. All right.
Have a great day, everyone.
All right. Thank you. Thanks, Roger, and Brittany and Nancy, and IPS in general.